Just to reorient you, thanks, Sydney. Just to reorient you to the program staff, so that if you see us in the chat, you're welcome to chat any of us today. And if you need any of our emails, this is us, this is who we are. Feel free to reach out at any point to any of us, but generally Sydney is the main contact. So if you're ever in question about who can tell you what information, it's almost always Sydney. But we're all happy to respond to any questions or concerns you have. We go to the next slide. We wanted to do just like a brief recap of the SOAR forum that we hosted on February 9th. And it was a great time for those of you who were able to attend. Thank you so much for taking time out of your week and or commuting and driving to St. Joe's to be with us that day. It was a great time. We had over 60 people in attendance in person. We also hosted 2 virtual sessions with some more attendees. We had 14 of our birthing hospitals represented at the forum. Our keynote speaker was Neil Shaw, who had some really great quotes and takeaways from the day, but specifically one that we all kind of took to heart. He said that a bad system will always beat a good person any day. And one of the reasons that we're here today is to do some systems change to improve cesarean section care for birthing people in Colorado. We also did a work session during that day where we helped teams kind of work collaboratively on aim statements and brainstorming change ideas and thinking about their next steps as they're implementing this program at their sites. For those of you who weren't able to make it, we're happy to recap some of those activities during your coaching session this quarter. So if you haven't already signed up for a coaching session with our team, go ahead and do that. And if you weren't at the forum, we'll try our best to recap some of the highlights and make sure that you guys are up to speed on the activities that people were able to participate in. If you were at the forum, please use the chat. What was your favorite part? Or if there was a lesson learned or a big takeaway that you had, particularly for your colleagues who weren't able to make it, go ahead and share that with us. All right, and we'll go to the next slide. I wanted to just level set, as we often do whenever we start these kind of very brief 1 hour, once a month sessions that we have with you guys as teams about why we're here. And this is one of the things that we really wanted to stress at the forum, and we're going to bring it back again and again this year, that we as a program have 3 key aims. These might align pretty closely with what your particular hospital aims are. And if they don't, that's okay as well. But this program is really here this year to proactively address the Colorado rising in TSV C-section rate. You can see that here on the run chart, that slow creep that we've had since about 2016. And although we're still on average below the Healthy People 2030 goal, it's that increase that concerns us, and we want to get ahead of it and be one of those states that gets to stay under that goal. Our second goal is to narrow the variation in C-section rates that we see across Colorado birthing hospitals and among providers at birthing hospitals. And then finally, our big goal for this year is to examine and address the known disparities that are happening with C-section rates. That's nationwide in Colorado and specifically at birthing facilities. And so part of our data collection this year does involve race, ethnicity, and payer data in order to help examine those disparities and come up with change ideas to address them. I shared this at the SOAR forum as well, that we officially closed enrollment for this learning collaborative the day of the SOAR forum. And so those of you who are on this call and the teams that you see in place are your cohort for the year. This is it. We're not accepting any new hospitals. And so look around, get to know the faces on this call and on calls throughout the year. We have 25 birthing hospitals throughout Colorado, and that represents 42% of Colorado's birth volume. And so this is not an insignificant number or an insignificant impact that we can have on the state's C-section rates. And so I'm really excited both that you all are interested to join us in this effort and the fact that we have the opportunity to make such a big impact as a team. So I am going to pass it off here in just a second to one of our Banner Health teams. They're going to share out about how their site's using this program and where they are now. I wanted to set the stage and let you guys know that an expectation of participating in this learning collaborative is that you will share out at least one of the learning collaborative calls. And so the team at Banner is going to kind of give a sample of what we mean by share out. It can be very informal, it can be formal, it can be data, it can just be commentary. There's a lot of leeway on what that means, but this is a learning collaborative and we're here to collaboratively learn from each other. And this month, we are very excited to have the Banner Health team with us. And so team, I'm going to pass off the mic to you all, and we're actually going to pass off slides to them as well, Sydney, because they're going to run their own slides. And if you don't mind, before you get started, go ahead and do your own introductions for us.
Hi, thank you. I am Mary Fisher-Searcy. I go by Kate, that's my middle name, but Mary is also fine. And I'm the WIS Associate Director at Banner Fort Collins Medical Center, obviously in Fort Collins. And I've been in my position for a little over 3 years now. And I've been at this hospital for 8 years. We've been open for 9 years. So that's me. And then I also have Taryn on here.
Sorry, I couldn't get off mute. Hi, I'm Taryn Hybeck. I am a quality improvement specialist. I support Banner Fort Collins and North Colorado Medical Center. I also support McKee Medical Center, which no longer does maternal care, Sterling Regional Medical Center, and East Morgan Medical Health Center. So I do 5 facilities for quality. My specific departments are is WIS, but I also do multiple pay for performances at those.
So we've just kind of prepared a little quick slideshow with what our goal is going to be for this year with regards to C-section rates and kind of what we're already doing and what we're hoping to do in order to meet our goal. And I apologize, I'm not very good at PowerPoints, so hopefully you can see it. I don't know how to make it bigger, I'm sorry. I can at least do that. Okay, so like I said, we're from Banner Fort Collins Medical Center. We're a level 1 facility, so we deliver 35 weeks and above. We have a level 1 nursery. We do TOLACs. We have about 600 to 700 deliveries a year. And we don't have any residents. We're not a teaching facility. We just have an OB practice and a midwife practice. So in 2023, our C-section rate was 21.14, which is up for us. We're typically under 20 or even under 18. So that was kind of up. So that's something that we're looking into as to why. And our goal for 2024 is to try to reduce this below 20%. So what we already do, we have a very established midwifery practice. We have 5 midwives, certified nurse midwives that deliver in the hospital. And there's a very strong collaboration between our OBs and our midwives. So they work very well together and they communicate well. And I think that's really helped us with all of that. The Friedman's curve, we actually don't follow it that closely, meaning that we really don't restrict patients on time limitations for stages of labor or rupture of membranes duration, as long as everything is going fine. We try to let them push for at least three hours. We will absolutely do more if it's appropriate and safe. And we don't have any requirements for rupture or things like that, as long as everybody is safe. And then we also minimize elective inductions. So we require all patients to be a Bishop's score of 6 or greater in order to have an elective induction. We very rarely do an elective induction before 40 weeks. And we very rarely do elective inductions at all. So we've really tried to limit that and only do medical inductions, post-dates inductions, that kind of thing. And then also we have a pretty advanced spinning babies group. Over 50% of our labor RNs have completed the spinning babies course. We had them come and do a day-long course for us that we had a grant to pay for, and we were able to have many nurses and couple providers also attend that. We have a lot of provider buy-in on spinning babies, which I think helps, and we provide our patients prenatally with the spinning babies information so they can start doing some of that before they even arrive. We also have spinning babies posters in every labor room. And then we also have badge buddies for all the nurses and a very detailed reference book to help with spinning babies. And we do that a lot. So that's what we've already been doing. And then what we would like to do to try to meet our goal is we are increasing awareness through utilization of the SOAR checklist. We had not previously been using the SOAR checklist, so we're going to implement that, and we have implemented it. And then we also utilized the online document, the DOT document that North Colorado Medical Center came up with to make it a little bit easier for our providers to be able to do that. We're also going to really collaborate with all the OB and midwife providers to work on our C-section rates and be very mindful of that. And then we're going to start using the REDCap system to follow trends and see if there are any areas that we can improve on, if there's specific trends through utilization of that data. So that's my presentation.
Thanks, team. That was awesome. Guys, we have a minute here that we can pause and open it up to questions, either in the chat, or if you want to come off mic, go ahead and ask this team how they're doing, what they're doing, why they chose the next steps for what they're going to do. Leave the floor open here.
Great job. That sounded excellent.
Thank you.
I'll ask a question. My question is, with the decision to not do elective inductions, did that come out of COVID? Like for many of our hospitals, we've heard that because of COVID, they shut down elective inductions, and then it's just a care practice that they ended up continuing to do. And so was that like a decision that was made before COVID, during COVID, or is it just something that you guys have sort of made since then?
It was actually more after COVID. We're a small unit. We have 5 labor rooms. We typically staff 3 RNs, maybe 4. And the problem was we were having so many elective inductions on the schedule that we were running into staffing issues for elective inductions, and then having problems with medical inductions, being able to get in because we didn't have the staff to care for them and we didn't have the rooms. So we decided to basically kind of just put a pause on elective inductions, and we just never started them again, really, because there's no reason to do that. So it really kind of came out of really more of a staffing thing. I think there was one week, I remember we had like 12 elective inductions in one week. And I was just like, this is ridiculous. We can't do this with our size of facility. It's not safe for the other patients. And it's worked out really well. So, and all of our providers were very on board with it. It was not any kind of a fight in any way. And like I said, we still allow some elective inductions with specific situations and some of that kind of stuff. So we still do them occasionally, but not 12 a week.
That's great. Team, thank you so much for sharing. Guys, I hope that demystified what we mean when we talk about sharing out during the Learning Collaborative meetings. We'll offer you the opportunity at the end of today's call to choose a month if you would like to elect to volunteer a month that you will share out. Otherwise, we'll be contacting you and asking on specific months if you'd be willing to kind of come and share how your team is doing and lessons learned. Feel free to continue using the chat if you have questions for the banner team. But we're going to keep on moving. Our main topic for today is leading change. And so those of you who are on the call are the people at your facilities who have stepped up and said that this is an important issue, either for you personally, for your unit, or for your hospital. We have said that as a state, this is an important issue for us. And you guys de facto are the leaders of these initiatives. And so we want to make sure that you have some of the tools and tips that will be helpful for you. And so we're going to share out some guidance here today. Some of you on this call have been leading change for years or decades, right? And so as we're going, you have tips, you have advice, you have anything that you want to share in the chat. Again, we're here to collectively learn. And so please speak up, please add your wisdom. These are just sort of launching points that we're going to cover today as far as how to lead change successfully at your site. So you can go to the next slide. So John Cotter is a professor and a scholar on leadership and change management. If you look up any literature on change management, you will almost assuredly come across his name and his work. And one of my favorite quotes from him is that effective leaders help others to understand the necessity of change and to accept a common vision of the desired outcome. And so those are a few of the steps that we're going to cover today, and hopefully equip you guys in order to do that. You can go to the next slide. John Cotter uses 8 steps of leading change. He uses this change model. I'm not expecting you to memorize this. You're not going to have a test on it, but I am going to use this model as a great way to sort of stepwise through some of the main ideas and concepts for leading change successfully at your site. There are 8 steps technically. Today, we're actually going to talk through those first 6 steps, but we've paired them into 2 steps each just to make it a little simpler. But you can see here, we're going to talk about how you can assess and create urgency for change at your site, building your team. We want to talk about how it is that you can develop and then communicate your vision for change within your unit and your hospital. And then finally, we're going to give some tips on how you can empower your team to make change and then celebrate the wins of your team in order to keep that momentum going. So we can go to the next slide. One great way to create urgency is to examine your current performance and to compare it with other hospitals in Colorado. And so we're here to help you do that. And so to create urgency, looking at your baseline data is a great place to start. If you haven't already been submitting data to us as part of this program, we encourage you to start now. Now that we're in the 2nd month of our learning collaborative, and our team can help you look at where you are at the beginning of this year. And we do that through a couple of different types of measures so that we have a more holistic view of how your hospital is performing. One of the types of data that we collect is what's called structure measures. And that's an assessment of the policies or the standards of work that you guys have in place to support birthing people on your unit. We measure those on a Likert scale, a scale of 1 to 5, and you guys fill out those assessments once a quarter. And it's really just your opinion or your assessment of, yes, we have a policy for this, or yes, we have a protocol for this. And those are the things that really offer the foundation for improving care. The second type of data that we measure is called process measures. And those are those evidence-based practices that actually impact the care. So for example, it's the use of a clinical care checklist in order to accurately diagnose labor dystocias. It can be the use of a category 2 electronic fetal monitoring algorithm that you guys use. So again, an evidence-based practice that you have in place in order to affect the outcome that you want to see. And finally, we look at your outcome measures. So we're actually examining your NTSV C-section rates, and we get that data from the Department of Public Health from your birth certificate data. And so again, it sort of offers an even playing field of all of the hospitals. We're sourcing the data from every hospital from the same source, which is the Department of Public Health. And so those 3 types of measures can really help your team decide, where are we now? How urgent is this issue, and where are our opportunities to improve? And then where do we want to be based upon where we are now? We just heard from the Banner team that their C-section rate was 21%, which again, might sound really amazing for some hospitals, or really unattainable for other hospitals, right? Because we're able to maintain 1%, now they're sort of changing that goal down to 20%, right? So individualized assessment of where you want to be is what we're to help you guys out with. And so the equation here that I like to say is that it's the structure and the process measures that lead to the outcome, right? We can't just say we want to lower our C-section rate. We have to talk about what's in place to help us do that, and how are we actually going to take steps towards that goal. So that's creating urgency. Let's go ahead and go to the next slide. I'm going to actually pass this one over to Victoria.
Hi, everyone. So nice to see you all after the SOAR forum. Am I off mute? I am. Okay, good. Yeah, so like, I think it's important to speak to, like, what are we talking about when we talk about creating urgency, right? And really what I think creating urgency is in Kotter's model and more broadly is really combating complacency, like a mindset of complacency, and really moving past that common phrase that we often hear when we're initiating change, which is like, well, this is how we've always done things. Like, why change? So a sense of urgency here is really motivating staff on your team and also leadership at your organizations to really recognize first the need for change, which can be a very formidable barrier, and then, initiating the steps to take action to really realize that change. So a really instrumental part of creating this urgency, especially in the QI world, especially in healthcare settings, which can be exceedingly complex, is really aligning your project with the mission, vision, and values of your parent organization. So when QI projects, or really any project, is clearly aligned with your organization's goals and values, it really builds buy-in. And it solidifies the perception among leadership and also just among staff in general that your project is relevant and actually essential to the organization's success. And it might seem kind of easy at first glance, or like straightforward, right? Like, who doesn't want to improve patient outcomes? I think we can all agree that that's a common goal that we all share. I've worked in healthcare so long, and I've never met someone who doesn't want to improve patient outcomes. But we really want to articulate what that means, and really be strategic and intentional about how we're communicating our goal to leadership. So there are a few things that you can do to build urgency, right? Like strategies that you can take. And the first, I think, I've already spoken to a little bit, but I'll just reinforce, is really knowing your organization's mission and vision inside and out. So we want you to know it well, to speak to it often, to reference it with meetings that you might have with leadership, with your team, in written project plans, like really wherever and however you can. And I encourage you all to read your facility strategic plans. These are often publicly available documents. As you all know, hospitals are required to conduct community health assessments every several years. So your team should really dig into those, right? Like, you can glean a lot just from reading those documents, and really articulate exactly how your project fits into the broader goals and strategy of your hospital. This is really how you begin to build influence. Like, this is how you build momentum. It's how you sustain change. It's how you initiate it. It's really, really critical. And it's really the power of persuasion. And then the second strategy that I think is often overlooked and incredibly effective is storytelling. Humans have really used storytelling to connect with one another and communicate for like time immemorial, like literally as long as we've been here. It's been a sort of key part of just the human experience. And telling stories is really powerful. It helps connect us. It evokes emotion, and it grounds us in empathy, really fosters like a shared sense of humanity. And it's so interesting because studies have actually shown that humans are much more likely to remember information when it's conveyed through a story, because they really help us transmit values. They help us make sense and meaning of the world around us. So we really want you to consider here, when you're thinking about how to bring, how to communicate your work to your organization, and maybe even more broadly, like, what stories can we tell about patients with them? Not for them, but with them. What stories can we tell about ourselves? Like, what is the broader narrative context of what we're doing together, and how can we communicate it? And who is best positioned to communicate it, right? Like, is it a patient? Is it a team leader? These are things we want you to start thinking about. And I think another point I just want to make here is that storytelling can help us reframe uncertainty, which actually mitigates burnout. So it connects us to something bigger than ourselves, and appeals to the heart, as you can see on that first bullet point. So as an example, we just wanted to briefly, on the right-hand side of the screen, you'll see CPCQC's vision and core values. And this is just an example using our own organization. This was something that was drafted up recently by the team. And really, these are truly more than just words at CPCQC, right? Like, we reference this often. It is the yardstick for how we measure progress and success in our work. And all of our programs are aligned with the vision and values you see here. And if we aren't advancing our vision or embodying the core values while we do it, like, we know that we need to return to the drawing board, we have to regroup, and we have to course correct. So very powerful to use vision and value statements to offer context, purpose, clarity, and strategic direction for your work. Next slide, please. Okay. So, casting vision, it doesn't just happen at the leadership level. Like, we want you to be empowered to have missional direction as well, to align that with the parent organization, but also be very clear about your team's mission and purpose. So in QI work, we call this a charter, essentially. And a team charter is really, you can think of it as like a foundational document that's just mapping out your QI work. It's typically identifying like your purpose. It's listing out the team members, like who's on the playing field, what are their roles, what are the resources that are available to you, and when and how will you communicate throughout the project. And really, by negotiating this at the outset, you're really setting up your QI project for success, like right out of the gate, because it's a clear blueprint for your goals, your expectations, and any workflows that you might have. And it helps keep a diverse team on the same page. And this really resonated with me when I first heard it, but this came up once in QI work. If someone walks up to 5 different people on your team at any given moment in time, each one of them should be able to articulate the purpose, goal, and scope of your QI work. And without too much variation, right, in the answers. And this is super important. So the team charter really helps synthesize that and really solidify it. And you might remember the aim statements that we worked on at the SOAR forum. And just want to be clear that the aim statements sort of they live within this charter. So you can think of the team charter as the big container that holds all of your work and really defines the parameters of what you're doing. So between now and your first coaching session, which is coming up quickly, we just want you to consider the questions here on the screen, right? Like who's on your team, who might be missing, who can you recruit, and how can you recruit? And my personal favorite, but how do you center patients as being part of the team? Because they are part of your QI team. So really think towards what that might look like and what engagement strategies you can use to solicit and act on any feedback that they might provide. So just like a little bit of homework, but we'll revisit this at your first coaching session and help you draft it out. So you don't have to do anything tangible between now and then, but we do want to get your gears turning about it. And we will revisit when we see you in one-on-ones. And I'll pass it back to Amber.
Thanks, Victoria. So we worked through the first couple of steps here. We tried to create some urgency. We're building our team, and then the next step is to help develop a vision for what your team wants to do. And honestly, sometimes the hardest part is just deciding where to start, right? Anytime you undertake a new quality improvement project, it's sort of like there's so many things that you could do and you want to do them all at once, but your time is really limited. And so we wanted to talk through a few of the ways that you might be able to prioritize your time and really develop a more specific vision for what your team is going to do, other than very broadly reduced NTSVC sections. So first of all, the expectation is that you will have more ideas than you have time, right? And for those of you who are at the session at the SOAR forum, you know that we spent some time just coming up with change ideas. We came up with 100 change ideas during that session, and there's no way that any one team can even do a handful of those and do them well. And so expect that you're going to have more ideas than you have time to execute on. The AIM patient safety bundle that this program is based upon, I really encourage you to think of it as a menu of quality improvement options and not a specific recipe that you have to follow. And so we have very few hospitals that are taking that patient safety bundle right off the shelf and implementing it exactly as it is written, because for many of you that the capacity just isn't there, right? Like your team is stretched in many different directions, but that doesn't mean that you can't choose pieces of it or parts of it that would benefit your hospital. And so again, treat it as a menu and not a recipe. And then I wanted to talk a little bit about Pareto charts. I'm going to get into this in the next couple of slides, but it's a really valuable data tool that can help your team identify the highest impact areas that you should tackle first in order to have sort of the biggest success right off the bat. I also don't want you to overlook the impact of structure measures. I just talked about measures on one of the previous slides and how those structures really create a foundation. And not only do they create a foundation for all of quality improvement, but those are the things that really help you sustain the improvements once you achieve your goals. And finally, we're going to talk through what is an impact and effort matrix, and we're going to do a breakout session here in just a minute to talk through how that might benefit your team. So we can go to the next slide. Back to Pareto charts. So what is a Pareto chart? This meme is one of my favorite ways to think about the intent of a Pareto chart. So if the goal is to support earth-friendly practices, fossil fuels, which is parodied here as a mega yacht airliner, is probably going to play a bigger role in impacting that than using paper straws, right? And so the Pareto chart, the rule is that they use the 80-20 rule, which says that about 80% of the problems are the result of 20% of the causes, right? And so our goal is to find that 20% of things that has this outsized impact on the outcome that you guys are looking at. And they really help us to prioritize and decide where we should start first, or what's the best cost for our money, right? Like, we have very limited time, and if we could focus that time anywhere, what's the best place to put that time? So we can go to the next slide. This is a Pareto chart of our 2023 data. So this is from the hospitals that participated in 2023. And so it looks like a bar chart, a traditional bar chart. From the left to the right, you can see that the first bar is non-reassuring fetal heart tracing. The second one is labor dystocias. These are the indications for NTSV C-sections that hospitals reported to us in 2023. Those lower bars then go on to say some of those were elective, some were for maternal complications, others were for fetal complications. But just glancing at this chart, you can see here that clearly 2 of those bars are bigger than all of the others. And those 2 bars are non-reassuring fetal heart tones and labor dystocias. The red line represents what percentage of the outcome, what percentage of NTSV C-sections were caused or indicated by those 2 heavy bars, right? And so clearly you can see here that those 2 are where you should focus your time and energy. And your Pareto chart might not look exactly like this one. This is like several hospitals combined. Maybe yours truly has labor dystocias higher or lower than what you see here. We can make a Pareto chart specific to your facility if you would like to do that. But this helps us focus our attention. If we wanted to say, you know what, I want to look at fetal complications as an indication for NTSV C-sections, be a fun academic exercise, but the impact that you're going to have on your NTSV C-section rate is going to be relatively small for the effort it's going to take to do that investigation. So we can go to the next slide. So getting a little deeper into the indication for NTSV C-sections, we are continuing to collect this data, and this is something that you guys submit to us as part of this program. So on the left-hand side here, you can see a bar chart of the average criteria of patients who met the diagnostic criteria for those diagnoses, right? So of patients who had an NTSV C-section for arrest of descent, just a little over 75% of them actually met that criteria and should have had an NTSV C-section for that criteria. If you go to the blue one for arrest of dilation, of patients who were diagnosed with arrest of dilation and then went on to have an NTSV C-section because of that diagnosis, only 50% met the criteria that's listed from ACOG and SMFM, right? These are the things that we're actually trying to dig a little deeper and focus our time and effort on. We have this information from your hospital if you've been submitting data to us, or if you're just now submitting data to us this coming month. This is the type of data that we're able to report back to you, so that you can say, you know what, this quarter we can only focus on one thing. What should our one thing be? Clearly from this bar chart on the upper left-hand side, it should be arrest of descent, right? It should be arrest of dilation. Those are the ones that we're least likely to diagnose accurately, right? And so these are the ways that we're able to use data in order to identify how should we be using our time, how can we be most effective in our efforts. We can move on. I'm going to not spend a lot of time on this slide. These are the structure measures that we assess. Again, you get a Survey Monkey, you get it once a quarter. Only one team member from your hospital should be filling out this survey. And for most hospitals, it's actually the nurse leader of the team who's filling out this survey, because they're the closest to the work and what is actually happening on the front lines among the staff. And so your nurse leader or champion of this program should be filling out that survey once a quarter for us. Of the responses we've had so far, you can kind of see on that Likert scale, 1 to 5, 1 meaning we're not there at all, 5 meaning we've already done that. It's old news. It's like standard of care at our site. You can see that not many hospitals have a patient support network communication following an unexpected C-section. That's something that we need to work on as a collaborative. Whereas you can see that mostly 5's unit policies and procedures for labor support are almost uniformly in place among our hospitals, right? That doesn't need a lot of time and attention for us. So again, your structure measures that you submit back to us help you then to identify where you should be focusing your time and your effort for your team and how you can develop your vision. We're going to spend some time doing an activity, and I'm going to turn it back over to Victoria. But I will say before I hand it over, if you have the ability to turn on your camera when you're in a breakout room, I highly encourage you to do that. Thanks.
Thanks, Amber. Yes. Okay. So we have an interactive breakout exercise with something called the an impact effort matrix. Some of you are probably familiar with this, but if you're not, this is a tool that's used in QI and project management to really help teams prioritize like what tasks or projects, how much effort and impact do each of them have, and how can you sort of prioritize them based off of that criteria. So it's divided into 4 quadrants. You can see on the y-axis, we have impact. On the x-axis, we have effort. So that yellow box, is high impact, low effort. So these are quick wins that we should prioritize in whatever work we're doing. Then we have in the blue quadrant, right, high impact, high effort. So major projects that require significant investment and careful planning, but have really high impact and can be done in the long term. Green quadrant, these are low impact, low effort, like tasks that are easy to do, but they don't offer significant benefits. So we might consider doing them if we have time, but we're not really going to prioritize them. And then in the red, we have low impact, high effort. So, obviously these are tasks that we want to avoid or postpone or perhaps delegate out because they're going to require a lot of resources, but not offer much in return. So we're going to put you in breakout rooms. It's 12:40, so let's do 5 minutes. And we're going to ask you to complete, let me drop in the Jamboard. Because we're not going to have time to share out, we want you to record your answers as best as you can in Jamboard. Hang on, let me get this ready. And please use the Jamboard page that corresponds with your room. So if you're in breakout room 3, use page 3 of the Jamboard. You're going to take a change idea, either one from the SOAR forum, one that you want to implement. If you're stuck on the last page of the Jamboard, so page 6 right now, we have lots of different sticky notes and ideas to get you moving. And yeah, we will see you in a minute, in 5 minutes. Thank you.
Your vision is communicating your vision with your team, right? It's one thing to have a vision. It's another thing if your team doesn't know what that vision is or how to articulate it. And I love what Victoria said about, like, if I asked 5 different of your staff members, what's the vision for your cesarean reduction program, and they gave me 5 different answers, then you failed, right? I mean, like that is clearly like a failure in communication. Actually, Deming, one of the sort of like godfathers of quality improvement, also has a pretty funny quote. And he says that if you can't describe what you're doing as a process, then you don't know what you're doing. And so I also think that that's a good check for you all to decide, do we know what we're doing enough that like someone on our team could describe what we're doing if someone asked them about it? And so if you guys want to share in the chat how you communicate with your team. I, in my breakout just now, heard some ideas about how one of the teams is communicating with staff about their vision. Throw those in the chat. If it's a newsletter, if it's a bulletin board, whatever it is, throw your ideas for communicating with your team in your chat, because some of the biggest barriers to effective quality improvement is just communication about where we are now, where we want to be, and how we're getting there. Go to the next slide. We are also going to talk about how you can empower others. I'm going to bring us back to the team charter that Victoria introduced and that you guys can make during your first quality improvement session with us if you'd like to, because really that charter can help you identify who are the key players and what are their roles. And there should be a role for everyone, no matter what their position on their unit is. And so with cesarean reduction, this goes all from the C-suite down to like the frontline providers and nurses. Everyone has a role in reducing C-sections at your site. And if you guys can sort of wrap your mind and empower everyone at those different layers and structures, that they all have a role, what their role is, and what they can be doing actively to help your team, then that's really going to set you up for success. And so again, we can work on that with you in a team charter at your first quality improvement session. In order to make sure that every single person on your team feels empowered and a part of the change that you guys are trying to lead. And finally, the last step here that we're going to cover, yes, is you should be celebrating wins. This goes along with communicating with your team and empowering your team, is that if you're seeing successes, you need to recognize them and celebrate them publicly. You guys will see, those of you who are getting QI feedback from last year's Q4 data, almost every single QI feedback that I gave to the teams says celebrate a win, right? Celebrate something about what your team is doing. Maybe you haven't achieved your goal in TSV C-section rate, but 2 more nurses did spinning babies training. Recognize that, right? Do it publicly, do it in the newsletter at the staff meetings. Maybe you haven't done labor to social checklists on every single patient on your unit yet, but you just got your C-suite involved, right? And they're asking questions about your program and how you're doing. Let's recognize that to your staff, right? Find wins that are available, make them public to your staff in order to keep that momentum going. And so you guys are adding what you're doing to communicate. What are your wins? Do you have any wins to share with us? Maybe just in the past month since we saw you at the SOAR forum. Did anything happen that you would say, this was a win for our team, big, small, or otherwise? Share it with us here, and then find an opportunity to share it back with your unit in order to both raise awareness for the program and to celebrate the effort that they're putting in, even in these very early stages, especially if you're new to this program. We're going to keep on moving, and I'm going to pass it back to Victoria.
Thanks. Yeah, Sydney, I don't know if we're gonna have time for the poll right now, so I'm just gonna kind of go through it. Yes, so I think we'll definitely be referencing your celebrating your wins every learning collaborative meeting, and another rotating agenda item is going to be PDSA cycles. So we will be talking about PDSA cycles at every single one of our learning collaborative calls. And this is really because PDSAs are the engines for change and a really critical part of QI work. So they're sort of the heartbeat of quality improvement, and are really focused on what changes are you making and how is it going. So if you were at the SOAR forum, we did an exercise about PDSA. I know that they can be a little bit intimidating, although once you get going with it, you'll totally fall into a rhythm. But just know that we're here to support you. So we're going to be asking everyone to share out at least one point or another at every learning collaborative call, at least one PDSA that they've completed. But we're also here and available to be your thought partner, to help you think through what this might look like. So please don't hesitate to reach out. And on the topic of sharing, oh, great. Sydney's way ahead of me. I dropped in the same document. You can start to share out, just as Banner did earlier, just a few slides. It can be about your current state, where you want to go, a problem you've run into, a solution that you're working towards. We want to hear all of it. It's all super valuable. So please select 2 months of the year that your team might be willing to share out. And if we don't have any volunteers, we'll be reaching out to find one. And then Amber, I think you're up next.
Thank you. So just a preview as you guys are getting ready to wrap up today, and we get to say goodbye until next month. Next month, we've planned to talk about how to manage resistance to change. You will definitely have resistance to change. For those of you who have been in this program, I know that you're nodding and smiling at me because resistance is a given when you're leading change. And we're going to talk about some strategies and share amongst teams. How is it that you guys plan for resistance? How is it that you overcome it? What are the strategies that you've already used? And what are some really great evidence-backed ideas for you guys to help manage? We're also going to have a couple of our teams who are in sustainability share out next month about how it is that they achieved their NTSV C-section rates and how it is they plan to maintain those rates. And so if you're interested to hear success stories, this is a great session for you. And then we also have a hospital that's going to share out their very progressive intermittent auscultation policy. And so we know, I showed you on your Pareto that non-reassuring fetal heart tones is a leading indication for NTSV C-sections. It should be one of the things that we're tackling, and intermittent auscultation is a change idea. It is something that your hospital can try out in an effort to decrease non-reassuring fetal heart tones as a leading indication. And so you can hear from one of our hospital teams what their policy is and how they implemented it. So we just have, last slide here, a couple to-dos for you guys. So before the March meeting, if you haven't already, schedule your Q1 coaching session with our team. Reach out to Sydney to do that. I encourage you to share your data with your team. So if you haven't already shared your most recent NTSV C-section data with your team, put it on a bulletin board, a newsletter, an email. Make sure people are aware of where you are right now and where you want to go. If there are any short-term wins that you can share, throw them out there. Recognize people by name, recognize specific actions when possible. And then I want you, if you haven't already, one person from your team, ideally your nurse champion, complete our structure measure survey for us. And so there's a QR code here. We'll include it in the follow-up email as well. And then as soon as we get kind of a larger number of Learning Collaborative responses, we'll share theirs all back out with you guys to give you sort of a baseline look about where you guys are with those sort of foundational structures that you need in place to find success in this program. We will see you all as a collaborative back together again on the 27th. Mark your calendars. Feel free to invite every single person on your team. These meetings are available to any person in your hospital if you're part of our Learning Collaborative. And so market it widely. This session is also recorded, and so feel free to share it out with any of your teammates who aren't able to make it. And in the 1 to 2 minutes, I will leave the floor open for questions, comments, anything else. We are so glad to see you all today. Thanks for coming.
I'll just add, if there's anything that you ever want to see at one of these sessions, just let us know. We're really responsive to your feedback and want to make this space as tailored as possible to what you need and want to see.